small lecture. It's again one of the common cause of acute abdomen. Usually the patient present with acute abdomen, and it is one of the cardinal symptom of intestinal obstruction. It may lead to high morbidity and mortality if not treated correctly. And broadly classifying, we divide into two categories: dynamic obstruction, or you can call it a mechanical obstruction, or obstruction to the flow of the content of the gut. That is called a dynamic obstruction. And sometimes we have adynamic obstruction, when there is no actual obstruction, but the gut movements are non-propulsive. They are not moving the gut contents forward. So that is called an adynamic obstruction. And we have added the paralytic ileus or the mesenteric ischemia in this category, because in these two categories presentation is the same, like like an acute abdomen and intestinal obstruction, but actually there is no organic cause of obstruction present in these patients. Okay, so dynamic is where peristalsis is working against a mechanical obstruction, and adynamic when there is no mechanical element, there is no organic obstruction. Here peristalsis may be absent. We call it paralytic ileus. That could be because of many reasons. Some electrolyte imbalances can cause it, and can be because of the manipulation of the gut, or because of some inflammations, or it can be or the peristalsis is present but it is in non-propulsive form, like in cases of mesenteric vascular occlusion or pseudo obstruction. Okay, broadly we classify intestinal obstruction, mechanical obstruction into causes that are causing intraluminal obstruction. Intraluminal means within the lumen. So impacted feces, any foreign body, gallstones, basors, they are causing intraluminal mechanical obstruction, something within the lumen that is causing obstruction to the flow of the stool. Then it could be intramural obstruction, problem within the wall of the gut, that is causing obstruction. And this intramural problem can be tumors or the inflammatory strictures. They are growing, the tumors growing within the bowel wall causes obstruction of the lumen with its growth, or strictures, they cause narrowing of the wall in the specific place. Then obstruction can be extramural. Extramural, something from outside is causing obstruction. It could be adhesion obstruction, could be hernias, volvulus, intussusception, tumors. The problem is not in the wall, the problem is not inside, the problem is because of the compression or obstruction from outside, because of some bands, because of some sudden twisting, because of some stucking in some narrow place. So there is an external element there. We call it extramural obstruction. Okay. The symptomatology tells us what is the type of obstruction. Usually we divide obstruction into small bowel obstruction or the large bowel obstruction. Now, a small bowel obstruction is obstruction at the level of the jejunum or obstruction at the level of the ileum. Now, if you imagine, or if you think about the gut, we have around 2 meters of small intestine, and then we have the large intestine, which is wide board, and it is around the periphery of the abdomen, while the small intestine, which is too long in length but it is smaller in caliber, and it is inside the central abdominal region. So any problem in the small bowel usually present as central abdominal distension. Now we have divided it into problems which are of high small bowel and problems which are of low small bowel. Problem in high small bowel means problem in the jejunum. If there is an obstruction in the jejunum, think what will happen. There is an obstruction in the jejunum. The jejunum is too early in the abdominal wall, or in the abdomen. There is stomach, then duodenum, and then jejunum. When there is an obstruction in the jejunum, patient will have mild distension. The distension will not be too much. Patient will have pain. Patient will have severe vomiting, and vomiting will be earlier. And vomiting may be bilious, because if it is in the jejunum, it may be bilious vomiting. And as patient cannot have anything going distal to that obstruction, he may present to you with rapid dehydration. There is no absorption of fluids from the lower intestine, or the lower part of the intestine. So there will be rapid dehydration. So usually in patients with high small bowel obstruction, there is pain, vomiting, but very mild distension. And as the gut, the distal gut, it keeps on emptying its contents, the patient may not present with constipations like that in the large bowel obstruction. So we have a patient with profuse vomiting, with severe pain, and there is very mild distension of the abdomen, or distension is just in the upper part. As compared to that, if we think about the low small bowel obstruction, the bowel obstruction that is at the level of the uh, ileum, we have whole 2 meter of the gut which is behind it. So when there is constriction, or there is obstruction at the level of the distal ileum or the terminal ileum, the whole of the gut behind it, it becomes full of the contents, it becomes edematous, and the abdomen is distended. So we have central abdominal distension, it is more in the center. The peripheries are the gut, the large gut, so the peripheries are not distended. So we have central abdominal distension, we have severe abdominal pain. Vomiting occurs but delayed, because vomiting is when the gut contents, they are getting too much in quantity, that they are now backing in the stomach and then coming out. So it takes time. So in low small bowel obstruction, we have pain, we have central abdominal distension, but vomiting is delayed. Now if we talk about the extra presentation of these two conditions, uh, our small bowel has distinct features. The jejunum has valvulae conniventis. Just a minute, I will show you pictures. Okay, if we see the X-ray chest, sorry, X-ray abdomen, there are multiple air fluid levels. Now, these air fluid levels, they are more in the case of low small bowel obstruction, and they are in more in the center of the abdomen. But in high small bowel obstruction, as the problem is more proximal, so the amount of the air fluid levels will be low. They are not too much, but there are air fluid levels. Now out of these air fluid levels, we use a rule for these air fluid levels identification. Usually we use the 369 rule. The 369 rule is, if you're seeing a dilated loop of bowel, and if it is a small bowel loop and the diameter of that loop is more than 3 centimeter, it is taken as distended or dilated. For colon, we have this limit of 6, and for the whole colon. And out of that, only for cecum we have the rule of about 9 centimeter, that cecum can be up to 9 centimeter in diameter. So if you're seeing the air fluid levels in the abdomen, we have to look for the diameter of that distended loop, and we use this 369 rule to think about it as a normal diameter caliber or a wide diameter. I am looking for an X-ray, but it is just a minute. Okay, I will draw it for you. So it will be more easier. Okay, I will draw it here, and it will be more easier for you to understand. Now, if you are seeing an abdominal X-ray, and in that X-ray you see air fluid levels. Air fluid levels, they appear like this because that is a white line that is differentiating the fluid from the air. So we have this upper part as black and the lower part is white. The upper part is black in appearance and the lower part is whitish. This is the X-ray presentation. We have these like this. White is, the black is actually the air that is more blacker in appearance, telling you that this is an air level. Now, if we see it clearly, these have some specific shapes. Like if you are having appearance like this in that air fluid level, a through and through circular folds. These are called the plica circularis, which are in the wall of the jejunum. If you see these plica circularis in the wall of that air fluid level, it is very clear that this is the jejunal obstruction. But if you have an air fluid level that is just appearing like this, there is no plica circularis, there is nothing, we call it a distended loop of ileum, because ileal loops, they are characterless. If you remember, ileum is characterless. There are no plica circularis in the ileum. So when you are seeing the X-ray, you will see the concentric loops or the folds of the mucosa within that X-ray, and it gives you the appearance of jejunum. And if it is characterless, we call it these loops, these distended air fluid loops, they are of ileum. Another is the large gut obstruction, in which there is a big air fluid level and we have folds like this. If you see, the folds are like this. They are incomplete. They are arising from the both sides, but none of them is crossing to the other side. These are called the hostrations. These are the hostral folds. That is one of the specific feature of colon or the large gut. So we have these three presentations of the gut loops which are distended. We have the air fluid levels, and out of those air fluid levels, we can have the characterless ileum. We can have these. Sorry. We can have these holstrations, which can tell us this is the large gut obstruction, or we can have this plica circularis, which this valvulae conniventis, which tell us that these are the jejunal folds that are getting inflamed. And I will, when I will give you this, when we finish this lecture, I will search for some X-rays related to it, and it will be more clear to you. So we see multiple air fluid levels as well as the characteristics, specific characteristics of the loop that is inflamed or has increased in size. Now, size is also important. 3, 6, 9. 3 for the ileum and the jejunum, 6 for the colon, and 9 for the cecum. So this is the normal diameter. If it is, if the gut loop is more than this 3 in the ileum or the jejunum, we take it as a dilated gut loop or distended gut loop. In large bowel obstruction, the bowel obstruction that is in the large gut, again, there is distension, and now the distension is generalized. It is not just central, it is generalized. Again, the pain is not very severe, like the pain of the small bowel obstruction. Vomiting is delayed, dehydration is delayed. Patient present more with constipation. So the patient is having massive distension and constipation. The rest elements, they are progressive, but not of very severe intensity. Okay. Presentation, usually if we talk about the presentation, it could be acute, it could be chronic, it could be subacute, or it could be acute on chronic. Acute obstruction means there is sudden onset of pain, there is severe vomiting, there is distension and constipation. These are the 4 cardinal symptoms of any obstruction: pain, vomiting, distension and constipation. And these 4 symptoms, they have a different set in different level of obstruction. Like we said, in the high small bowel obstruction, we have severe pain, we have severe vomiting, but distension and constipation, they are not very marked. In case of large low small bowel obstruction, we said that there will be severe pain, there will be uh, central distension, constipation will be progressive, it will progress with the passage of time, and vomiting is delayed. And in the third one, the large bowel obstruction, we said that there is severe distension, there is uh, pain and mild pain, severe distension and constipation more marked, and this pain and vomiting, they are delayed or they are not very acute. So we have different set, but these are the 4 cardinal symptoms: the pain, distension, vomiting and constipation. Now, chronic obstruction usually occurs in the large bowel, and there is lower abdominal colic and obstipation, which is followed later by the distension, massive distension of the generalized abdomen. Sometimes there is a chronic obstruction on which uh, some acute insult. There is a background of pain and constipation for long, and then there is a short history of sudden distension and vomiting. We call it acute and chronic constipation obstruction. Then we may have subacute presentations, which are because of the incomplete obstructions. Okay. Uh, the If we talk about the pathophysiological classification, the obstruction can be simple, or it can be strangulated, or there is another element which is called closed loop obstruction. Uh, Simple obstruction means that there is blockage, but it is not interfering the blood supply. Strangulation means the blockade is of such an extent that it causes impairment of the blood supply, and it may lead to ischemic necrosis or death of that specific segment, and later on that can perforate. And usually these strangulated obstructions, they are seen in cases of hernias, volvulus intussusception, in cases of mesenteric infarction, and in external extramural causes like adhesions and bands. And this strangulation obstruction is a surgical emergency. And we have a closed loop obstruction, especially seen in cases of malignancies. If there is a tumor of the colon, uh, which is causing severe narrowing. There is an annular growth that is causing severe narrowing of the gut. The contents of the gut, they are being uh, blocked in a loop, and that loop is between the cecum and that annular segment. So the gut contents, they keep on rotating in that loop of bowel, in that segment between the cecum and that carcinoma. And the quantity increases a lot, and as the cecum is the most distensible part of the gut, it takes too much quantity before it bursts. So it is closed loop obstruction. Is presentation may be delayed, but the perforation is when the perforation occurs, it is a massive perforation, and the prognosis is not very good. The problem is also because there is carcinoma there, so usually it has a very bad prognosis. Okay. Okay. Generally speaking, the causes obstruction depends on the again the site. In the small bowel obstruction, the most common cause of obstruction is adhesion obstruction, and in large gut, the most common cause of obstruction is malignancies. Though generally speaking, as the SB or the small bowel obstruction, they are more common. Generally, we have adhesions as the most common cause, and then we have tumors, then we have inflammatory causes, then we have hernias as the causes, then intraluminal causes, and then there are some other rare conditions that may present as intestinal obstruction. Okay. Uh, what is happening in the segment which is having some obstruction to flow? In that specific segment, as the fluid secretion is increased there, there is distension in that specific segment. And with the passage of time, the H2S, this H2S gas, it starts forming from the fermentation of the contents inside, and that gas accumulation inside causes increase in the distension of the specific loop. This distension causes increase in the intraluminal pressure proximal to that loop. All this is happening proximal to that obstruction. So when there is too much intraluminal pressure behind or proximal to that segment, it will cause vomiting. With the vomiting as well as accumulation of the fluid in the gut, the body overall body fluid balance will be affected, and patient will develop dehydration. The patient will suffer from the inflammatory symptoms and signs. There will be dilatation of the bowel, and as a reflex mechanism of that inhibitory of that obstruction, the body tries to start extra effort. The peristalsis becomes hyperactive, and the patient complains of severe colicky pain. With the passage of time, when the stamina of the gut becomes decreased, the patient goes into the phase of ileus. So initially there is, if you see the abdominal bowel sounds, there is increased bowel sounds in acute obstruction. But with the passage of time, the abdominal remained distended, but the bowel sounds may not be heard, because now the bowel is in the phase of atony. And this all is proximal to the obstruction or obstruction site. Now what is happening distal to the obstruction? As there is some gut content inside, or there's some luminal content inside the gut, In the initial period, body passes or the gut passes some flatus, some mucus or some contents, but later on, some stools. But later on, as there is nothing in the gut left and the bowel is collapsed, patient's presentation is of constipation or sometimes some mucus discharge is there. So this is the pathophysiology, how these symptoms they are correlating with the mechanical problem. So the four cardinal symptoms are abdominal pain, vomiting, distension, and constipation, and they vary according to the location, according to the duration, according to the underlying pathology, and the nature of the ischemia. So if the ischemia is there, then the symptoms they also vary. So again, just the repetition. Abdominal pain is colic in nature. It is seen around the umbilicus in small bowel obstruction, while in the lower abdomen, in the cases of lower bowel obstruction. If it is colicky, it means it is obstruction. But if it becomes continuous, think about that the segment have become perforated or strangulated. Uh, it doesn't usually occur in paralytic ileus because paralytic ileus is a flaccid gut that is not moving. So there is no colicky pain or there is no chances of getting pain anywhere. Now, vomiting, it starts early in small bowel obstruction and very early in high small bowel obstruction. But in large bowel obstruction is usually late. And as obstruction progresses, vomitus alters from digested food to feculent due to the bacterial growth. Distension is more in the lower gut obstruction or the large bowel obstruction. When this obstruction progresses to strangulation, when the blood supply of that specific segment is obstructed. Patient was having previously a colicky pain, which was coming and going. Now the patient complains that I have severe constant pain at a specific position, and they may have fever. Vitals may be deranged. Now the patient may have tachycardia or tenderness with rigidity and rebound in that specific area. And sometime if it is associated with too much fluid and electrolyte imbalance and too much fluid loss, patient may go into shock. Okay. uh, Generally when we when we examine the abdomen and general physical examination, in case of shock, you may have tachycardia, hypotension. You may have signs of dehydration like dry mucous membranes, dry skin turgor is decreased, and urine output is also low. On abdominal examination, if patient is having a previous surgery, like in cases of adhesion obstruction, you may find scars. You may see the distension, and distension location can also tell you what type of obstruction it is. You may see the visible peristalsis on the abdomen. Hernial orifices needed to be checked because sometimes patient is presenting to you with abdominal problem and even pain in the abdomen, and patient doesn't bother about the site where the hernia is obstructed. Sometimes it is the W-shaped hernia in which the problem is intra-abdominal, but the loop of the gut is obstructed at the hernial orifice. On palpation, check for tenderness, check for the masses, and check for rigidity. Rigidity is involuntary guarding. So if there is involuntary guarding, think about strangulation or perforation. Percussion, usually as the gut is distended and full of gases, the abdomen is tympanic on percussion. And auscultation, initially we have high pitched vowel sound or tickling sounds, and later on it is a silent abdomen. And not but last but not the least is you have to examine the specific 5 areas. You have to see the rectal area, do a digital rectal examination, look for the genitalia, look for the hernial orifices. If you're suspecting it a malignancy, look for the supraclavicular lymph nodes. And don't miss these things when you are doing an abdominal examination, because sometimes your diagnosis is hidden in these additional things. Okay. If a patient presents to us with acute obstruction, intestinal obstruction, we go for some investigations also. We go for a CBC, and that may show us a high neutrophil count because of the inflammation and ischemic insults. Uh, Electrolytes problems can be a cause of paralytic ileus, or electrolytes can be deranged in certain conditions of gastroenteritis and acute obstructions. Patient may have hyperkalemia, hyperamalesemia, or there may be a raised LDH. Hyperamalesemia is a sign of ischemic infarction or ischemic necrosis. So you may have a high amylase level here too. There may be raised LDH level, which may be associated with the strangulation. When we go for a plain abdominal X-ray, you may see the air fluid levels. You may see the specific patterns of the gut, which is involved in obstruction. In large gut obstruction, if the patient is having presenting to you with sudden severe obstruction, go for a sigmoidoscopy. Sometimes the sigmoidoscopy, it not only give you the diagnosis, but sometimes it also revert the cause, especially in cases of intussusception. If there is intussusception or valvulus, sometimes the sigmoidoscopy, when you are inflating the gut for the sigmoidoscopy, it reveals or it corrects your problem too. Then, if needed, we can go for contrast X-ray, especially in the case of large gut obstruction. And if the diagnosis is in doubt, we can offer a CT abdomen to identify the cause of this obstruction. Okay, general management of a patient with small bowel obstruction is: a patient presenting to you with severe abdominal pain, he is vomiting, he is having abdominal distension. So first thing you will do is you will make the patient nil per oral. Patient should not be taking anything by mouth. You will start IV rehydration, IV fluids to the patient. You will pass an NG tube and you will start decompressing the gut, so as to reduce the load on the gut, because that area of the gut that is loaded with fluid or loaded with the contents is prone to undergo perforation. So you have to be vigilant and decompress that proximal segment with the NG tube. Monitor the input and output and check for the dehydration status. Patient is having some decrease in the urine output or not. Start IV antibiotics, and as we are taking it as an acute obstruction, do frequent clinical assessment. And anytime you are suspecting that patient is showing high grade obstruction, or the patient is having strangulation element in it, go for operation. Some cases of obstruction will settle by using this conservative regime. This is a conservative regime: NPO, NG, IV fluids, IV antibiotics, gut rest. These all are included in the conservative therapy. So sometimes when we are giving this conservative regime, usually some of the cases they settle down. Usually seen in the cases of adhesion obstruction or incomplete or subacute obstruction. Just by the conservative management, your patient is settled. Surgery should be delayed till resuscitation is complete, unless sign of strangulation or evidence of closed loop obstruction are seen. Cases that show reason for delay should be monitored continuously for 72 hours in hope of a spontaneous resolution. Don't take it beyond 72 hours. In there is a very I can say this is a very beautiful saying that is by one of the very earliest surgeons, that sun should not both rise and set in the scenario of an unrelieved obstruction. It means that if you are having a patient presenting to you with obstruction and you started resuscitation, but the patient is not settling, and you started it in the morning and now it is the evening time near, don't take too much, don't observe too much. Now take the patient for operation. This is for the unrelieved. If the patient shows sign of relief, you can continue you can continue for spontaneous resolution for 72 till 72 hours. Or sometimes if the things are becoming things are becoming better, you can increase it also. But if it is an unrelieved obstruction, don't make it prolonged, do it within the same day. Okay, so this is the take home message for this lecture, that you have to manage an unrelieved obstruction within the same day, but after preparation. Don't take a dehydrated unresuscitated patient to the emergency operation theater, because when you will open the patient will suffer more insult, and all this will add fuel to the fire, and patient will have a high mortality or morbidity rate. Now, in cases of acute obstruction, when should we go? When should we plan for surgery, or what cases they need surgery? There are cases with virgin abdomen. A patient who is having adhesion obstruction, usually we give more frequently. We give trial of observation and conservative treatment. But virgin abdomen means the patient has no previous adhesion obstruction. So no previous sources of adhesions. So if there is no previous source of adhesions, the problem can be serious. You have to open the abdomen, as your resuscitation plans are not working. Then if the patient, you have given the conservative management for 72 hours and patient is not responding, there is no complete relief of the obstruction. If the patient is having a tender irreducible swelling at any of the hernial orifice, or if the swelling which, or this hernia which was initially this obstructed, and it was irreducible, now it becomes strangulated. There are signs of strangulation over that hernia. So when you are having any of these things, it makes your mind it makes a hint to your mind that now you have to think of surgery. So when we open these patients, the first thing that we do after opening the gut and the affected segment, first check for the viability, whether the gut is viable or not. If the gut is viable, give trial, and we don't have to do anything for it. Just you have to release the obstruction, you have to cut the bands, you have to remove the thing that was obstructing that area, you have to release that obstruction. But if you see that even after releasing the obstruction, the part of the gut is non-viable, it is black in colored, or it is not showing any visible peristaltic activity, you have to resect that area. You have to resect that specific segment, and you have to stitch the mesentery and the gut again. You have to repair that. You have to cut that segment, and you have to do anastomosis of the proximal and the distal segment. Now, for adherence, what we can do, we can go for adhesiolysis, and now this adhesiolysis should not be generalized. Only we have to do adhesiolysis of the adhesions that are causing problem, that are actually causing mechanical obstruction to the flow, because adhesions, whatever you will remove, they will come again. There is no stop to the adhesions. So you have to make your things very clear that you should do meticulous surgery. You should not use your hands at every place, like even in the place where it is not needed. You have to take care not to do extra insult to that area, and try to cut only the adhesions that are uh, notorious for that specific obstruction. If there is a mass, if there is a luminal mass, take out that mass. If there is a tumor in some specific area of the gut, take out that area, resect that segment of the gut and come out. If there is a hernia, reduce the content, check for the viability of the gut, and then repair the hernia. So whatever is the cause, you have to treat the cause. But for the gut that was obstructed in that area, first you have to check for the viability, the gut is viable or not. How can we see the gut is viable? There is visible peristalsis, the gut color is bright, it is not dull or bluish or purplish, and when you pat it, it shows visible peristalsis there. And one more thing is, if you are seeing the mesentery, you can palpate the mesenteric vessel, whether the mesenteric vessel is pulsating or not. So these are the few things that can tell you that yes, the gut is viable and you can continue. But if you are having features that the gut is not viable, then you have to resect that segment. Otherwise, it will perforate. If you put it inside like this and you close the abdomen, patient will present again with acute perforation. Okay, you want to ask anything from this? Anyone ask any question? Okay. Okay, if you want to take a break, I will start lecture after 10 minutes. 11:40, or you want it now? After 10 minutes, I will inshallah start. 11:48, I will start at 12 o'clock.